Welcome back, everyone, to another fabulous episode of the Healthcare Trailblazers podcast. I am very excited to be sitting here today with a very, very prestigious doctor from the Baltimore and Washington, D.C. area, Dr. Esti Schabelman. Dr. Schabelman is the chief medical officer at two extraordinarily large hospitals. One of them, Mount Sinai, is the flagship hospital of their group, of the entire group of I think it's a total of 5 hospitals. So you must have a ton going on, and I really appreciate you taking the time to come sit with us today.
Thanks, Mendel. Not to be confused with Mount Sinai, New York. We are Sinai Hospital of Baltimore.
So. Yes, my apologies. They get confused. So take us back to day one. Where'd you grow up, and why healthcare?
Well, I grew up in New Orleans.
Okay.
My family are Argentinian immigrants. So, if you ever see a Hispanic first name, my full first name is Esteban.
Okay.
Esti is a nickname. So if you ever see a Hispanic first name and a Jewish last name, you can be pretty sure they're from Argentina. My family, my dad's a cardiologist in New Orleans. He came over from Argentina in the 70s. And, so medicine was always a potential career. I was always very interested in public policy, in the way the way things get done, the way the sausage gets made. I really enjoyed the politics and the policy behind it. And I always thought I was going to go into policy, not necessarily medicine. I was a politics major in college. I did biology as a sort of side gig. Then I ended up deciding to apply to medical school for various reasons, but one of them actually, and this is an interesting story, was being held hostage by guerrillas in Colombia. So we went to go visit some friends in Colombia, the country, we spent some time being held hostage by guerrillas there when we were coming back from a short trip to the countryside, and we ended up hiding in the villages of the countryside.
What?
From the guerrillas. Yeah, it's a great story.
What?
And we saw all the villagers in the countryside that had really bad healthcare. Honestly, I mean, we talked to them for a while. Remember, my dad's a doctor, and so he had some. He wanted to take pictures. Actually, my mom was like, "Absolutely not! You cannot take pictures of this." But he'd ask them questions about their healthcare and about what was going on in the countryside and why the guerrillas were fighting and that kind of thing. And I learned a lot about sort of third world healthcare. It feels kind of weird calling Colombia a third world country. It's not really now, but it was at the time. I got interested in that sort of thing, and I always thought I'd do international medicine. So I'd applied to medical school with the intent of doing international medicine, and then got married and had a family and couldn't really do that.
Right.
And so I started working at a critical care access hospital here in Baltimore called Bon Secours, which is actually now called Grace Medical Center. It's that small hospital that we bought. It was as close as I could get to that kind of thing. I did get to do a small engagement in Panama, building an ER and building a chest pain center. They call it the Chest Pain Center of Excellence.
That's cool. Did you do that from here? Or did you go out there?
Yeah, I was working for Hopkins at the time, and I had an administrative bend, was an ER doc, and spoke Spanish. So I don't know how many choices of people they had, but I ended up going out to Panama and helping them sort of create an American-style ER there.
That's really cool. How long did that take?
3 months.
3 months? So you lived there for 3 months?
I lived there for 3 months, yeah. My wife learned Spanish, learned how to scuba dive. It was an interesting project, I'll tell you, because, they had an ER. It just was a different sort of thing than you would imagine. They have a private and public healthcare system.
Okay.
So you could come into the ER's front office with horrible chest pain, and they'd say, credit card, please. And if you didn't have the credit card or if you didn't have the cash deposit, they'd call an ambulance for you to take you to the public hospital. But they wanted it to have they wanted to have the American standard of, door to balloon time for caths, for cardiac caths. So essentially, we had to rejigger the ER to make sure that everyone got a free EKG, which was, incomprehensible. What do you mean free EKG? I mean, like, there's no free care in this
Yeah,
hospital.
who paid for all this?
Well, the hospital ended up paying for it. Honestly, they wanted to have a joint commission, an international joint commission certification. In order to do this, they needed to make some compromises, and that was, some throughput changes. The asking for the credit card had to happen after triage, so they had to have sort of a free triage system. And they had to even, if someone actually was having a heart attack, um, they they went straight to the cath lab. There's no time to do the billing thing, and so the hospital ended up probably providing some free care for people who were having heart attacks, but they did enough to get certified. So.
That's fascinating. Wow. Did you have any kids while you were out there?
No, that was before kids, and
Okay.
that was a real, uh, that was what I wanted to do. And then we had kids, and it became hard to travel as much, and so I wasn't able to do that kind of thing.
And thankfully you didn't get held hostage by any kind of guerrillas or anything while you're out there.
Yeah, man, Colombia was a crazy experience.
That's nuts. How long were you hiding out? You said 3 days?
4 days. Yeah.
4 days. Oh my goodness. And so your dad the whole time was just going around and being a doctor for everybody?
No, but he's a cardiologist. He's also an amateur photographer. I guess semi-pro photographer. He does
Right.
certainly gets paid for stuff, and
Right.
so he was interested in taking pictures. And he would also ask people about their health care and things like that. But he wasn't helping medicate people at that time.
Right. How old were
We were
you then?
busy. I was 16.
Okay.
Um,
Okay. So
and I
definitely
was
you could remember it.
Oh yeah, I remember it. Now fortunately, it was scary, but the guerrillas were on. It was the FARC,
Okay.
and they were on a recruiting mission, not a murder and pillage mission. And
Did you
so,
see them at all?
oh yeah, no, no, they made us sing songs to them about how great they were. I still remember the songs. Um,
I'm sorry.
and
I'm sorry.
so
We need to dig into this a little bit more. I'm sorry. I'm not getting a full picture here. So you're traveling
so
and you had a destination. Where were you trying to go?
we were coming back from this giant meteor. Uh, that called El Peñol, which is outside of, I forget if it was Medellin or Cartagena. And on the way back, in the middle of nowhere, um, my mom, my dad, and my brother, uh, we had a driver as well. We're kind of sleeping in the back seat, and the driver says, everyone keep quiet. And we wake up, and there's a guy with an Uzi pointing at us in the middle of the road and a bandana over his face. And we ditched our American passports. We hid them in the car. And when they asked us to get out, we all spoke Spanish, except my brother, who had an accent at the time. So we told him to stay quiet. Um, so we all spoke Spanish. We said we're from Argentina. We said how much we sympathized with them and their plight, because Argentina at the time had had of a quasi-military government. And so we were kind of friendly with them, fortunately. And so they took us to like a central square in the middle of this village and made us sing. They taught us all the songs that we should sing to them.
Are you
Um,
serious?
yeah, my dad made like a
Talk
300
about
yard,
being
whatever he had.
emotionally needy, gorillas. Come on, guys.
Well, they wanted to recruit me specifically.
Oh my
Because
gosh.
16 is like prime recruitment age. And I pretended to go along with it. I said I'd be very happy to join. I just needed to go back home to Argentina, which is not where my home was, and clean out my parents' bank accounts, and then I'd be right back.
And they bought that?
Yeah, they bought it.
Oh
Yeah.
wow. Oh my
So
goodness. Oh my goodness. Talk about a formative experience. That's
yeah,
crazy.
yeah.
That's
So
crazy.
that and again, I was always interested in sort of the policy side of things, and this made me more interested in the sort of healthcare policy side of things.
So why did that translate into policy in your head? Why was the policy
Well,
interesting to you based on that experience?
policy had always been interesting to me, but the just the healthcare disparities that we saw, we traveled a decent amount when I was a kid, but always supervised and kind of, we went to we'd go to Hong Kong, and it was a nice trip, and we'd go to the outdoor markets, and that, but seeing poverty like we saw it in the villages of Colombia, where people lived in mud huts. I mean, that's a little bit of an exaggeration. It's like adobe, but made of mud. Um, and didn't have access to running water, and didn't have access to a bathroom, and had open air latrines and things like that. Um, really made me think that a couple policy decisions that could have made a big difference. Um, and also, the people we spoke to in the villages complained a lot about the way that they weren't all against the guerrillas. I mean, that they complained about the government policies that had forced them into poverty, made them unable to farm, and kind of empowered the guerrillas. So,
Wow. So you envisioned that you would go back out there and affect policy overseas, over there.
yeah, well, I thought about doing, medical healthcare policy overseas. In fact, when I was in college, I ended up working for the first Scottish Parliament, for the chair of their health and community care committee.
Okay.
So in 1999, um, uh, the Scotland devolved from Great Britain, meaning that some of the powers that were previously part of the UK's Parliament were sent back to the Scottish Parliament. And I guess I was a junior in college, and I called the Scottish Parliament that was like brand new, and I said, this is what I want to do. I want to do international healthcare policy. Do you guys need an intern? And they had no idea what an intern was. No clue.
Is that
they'd
because
never
nobody
heard.
there got paid, or because everybody got paid?
No, there was just there's no tradition of doing an unpaid internship like
Okay.
that. College kids doing that. It didn't exist. Um, and but they put me in touch with the head of the health and community care committee. Um, and she like picked up her own phone. That's where they were at.
You literally
And she was like,
called them.
yeah, yeah, yeah. I called her on her phone.
Okay.
And she picked up, and she was like, "You mean you don't want to get paid?" And I was like, "No, no, no. I'll just come over, and you just sign up some forms saying I got credit for my classes and whatnot." And it worked out really well. I ended up taking classes. I ended up taking classes at University of Edinburgh.
Okay.
I ended up working for the Scottish Parliament, the first Scottish Parliament since like 1700s, and helping them put together a report on sort of the other healthcare systems in Europe and how they do it, so that they could come up with how they wanted to build theirs.
That's
And
really, really interesting. I just want to take a
yeah,
second to appreciate the fact that, clearly you had a lot of experiences that nobody has. I mean, and it seems to me that you had a vision that you wanted to do something, overseas. You thought bigger, you thought out of the box a little bit. You went and you chased it, and that's what gave you these experiences. I don't think you sitting in your dorm room thinking about these things would have done any good for you. So
I did.
the fact that you were able to think that broadly at that young age and call up call up the parliament and say, "Hey guys, I'd like to intern for you. Please put me through to the front desk." I mean,
So the interesting thing is, it was apparently another girl had the same idea,
okay,
and so we were the first two Scottish Parliament interns, um, and we both took classes at Edinburgh. The classes were amazing. They were all tutorials, which means it was like you and a professor in a bar, literally drinking beer or cider and just talking about the books you read, and they'd assign readings. You'd read them, and then you'd talk about them, and sometimes there'd be a report at the end or whatever. But it was amazing.
that's amazing.
And now that internship program is official. Like, there's an actual thing, and they take, I think, somewhere between like 10 and 14 interns every year.
Well,
But
once you turn them on to the idea that they could get a bunch of free labor
right,
from some American kids, I'm
right,
sure they.
yeah. So it's like a going concern. They have like a whole housing program and everything for them, and we started that up. It was great.
That's fascinating. Wow, and that was while you were in college, you said.
That was my junior year of college. Yeah.
Wow, that's amazing. All right, so, um, so you get out of medical school. Where did you do residency?
So, in medical school, I still hadn't fully made up my mind. Remember, I still thought I was going to do medicine and policy. And so I did an MBA.
Okay.
I went to med school at Penn. Um, and my second year at Penn, I applied to Wharton to do an MBA. And my MBA was in it was a business and public policy was the major, as well as healthcare administration. So I double majored. And then when I finished, I had to make a decision whether or not to work in consulting because I'd done a summer consulting gig with Booz Allen. And so I had to make a decision about whether to continue with that because they offered me a job or or do a residency. Because if you don't do the residency right after, if you take maybe a year I could have taken, but if you take more than that, you forget all the information and then you can't really do the residency anymore and you're
Right. Can't
never
apply it.
never be a real practicing doctor. So I decided to do the residency. Um, and then after that things just kind of fell in place. Met the wife, got married, had a family, and then the international thing was kind of off the table.
Wow.
So,
Wow. So where's the first place that you worked after you graduated?
well, so after I graduated, my wife was doing a fellowship.
Okay.
She's an oculoplastic surgeon, and so
Oh, okay.
she went to Pittsburgh to do a fellowship.
Your kids are doomed. Your kids are doomed. Mom's the plastic surgeon. Dad's the chief medical officer at at Sinai. That's amazing.
They are doomed. Yeah, I don't know whether to talk them into or out of medicine. My wife
Right.
is adamant to talk them out of medicine.
Really?
Yeah. She doesn't like the the sort of
State of affairs.
Yeah, she doesn't like the requirement to bill and the time you spend doing notes and the time all the non-patient care stuff. She's kind of sick of it. So I followed her to Pittsburgh for 1 year.
Okay.
To do while she did her fellowship, and I worked at a small suburban hospital called UPMC Passavant.
Okay.
And it was a great experience because as a resident, we worked 21 12-hour shifts, but most attendings, just out of residency, probably worked somewhere in the 10 to 16 range. Because 3 days because you're switching schedules, so doing a night shift means you can't work the next day, right?
Yeah.
But I worked 21 12s because I figured I did it as a resident. I could do it for 1 year. And I got crushed. And they had this policy where if you got called in on a day that you were off, or if you worked a holiday, they paid either time and a half or double time.
Yeah.
And I lived next door to the hospital, so I took all the call days.
Oh my gosh.
I'll never forget working 10 days in a row. It was my worst. Yeah.
Wait, 10 days in a row you did what kind of shift?
12-hour shifts.
Oh my gosh.
And I had this horrible back pain. Yeah, it was bad. It was supposed to be 4 days on, 1 day off, 5 days on.
And you did 10 days straight.
And I got called in on the day off.
Oh my god. Oh my gosh.
So then we moved back to Baltimore because we had this is where I did my residency, and so we had a house, so it was just easier to move back here than anywhere else. And I started working for Hopkins at one of their suburban hospitals as an assistant director of the ED. That's where they sent me to Panama. And then eventually got this job as a director of an ED, and then a regional director, and then a chief medical officer. So sort of a standard path, I would think.
Got it. It's crazy because then we wonder why there's provider burnout and medical staff burnout. 10 days, 12-hour shifts. Oh my goodness.
I don't know how much you know about ER docs, but I hired ER docs for a living for many years, and they come in three flavors. There's good, right? That good quality. There's fast, and there's nice. And you have to have 2 out of the 3, or else you don't keep a job. Nobody keeps the nice guy with poor quality who's slow. That just doesn't happen. So I used
wait, what were the 3 things? You've got good, fast, and nice.
That's right, and you need 2.
So you can be nice and fast, but not necessarily good. But
yeah, unfortunately,
right.
Those guys usually go to, yeah.
Because if you're fast, that means that you actually execute quickly.
Yeah, and
So
you're seeing more patients, and so you're providing some benefit to the group.
yeah, yeah. Or you could be
I mean,
Dr.
there's
House,
limits.
where you're
There's
good
limits.
and
You
you're
can't.
fast, but you're not nice.
I mean, there's limits. You can't be an axe murderer,
Yeah,
right? I
yeah,
mean,
yeah, yeah,
but certainly you could have lower quality if you're really fast and really nice to patients.
yeah,
Those guys usually end up working night shifts.
yeah.
Um, but but I used to be good and fast, for sure.
Okay.
When I was working those 2112s, I was good and fast, but I wasn't nice. I was burnt out. I was not happy to see patients. Um, I was not happy to see people who didn't need emergent care. You know, people come into the ER with 6 months of knee pain, and I was not super nice to them back in the day. And and now that I'm working fewer shifts and feel less burnt out, um, I, I I hope I'm still good. I'd like to think so,
I don't think that
but
goes backwards. It
but I'm
only
not. Yeah,
it only
but I'm not
progresses.
fast. I'm
Yeah.
definitely not fast anymore.
Okay.
Now I'm nice. I'm super happy to see everyone. I'm like, oh, let me talk about your knee pain for the next hour.
Yeah.
Um, so I think that definitely has something to do with it.
That's interesting. So you're saying if you could change anything from back then, give you more time to breathe, give you more staff so that you don't have to do 10 days in a row, less shifts. So you're saying less shifts equals happier. I mean, it's pretty basic.
I think so. It's probably that number is probably different for different ER docs.
Mm-hmm.
But now that I'm mostly administrative, I work one shift a week,
Right.
which for an ER doc is probably about 30%,
Mm-hmm.
because most ER docs do 3 to 3.5 shifts a week.
So
Um,
what are some of the challenges with executing that? Now you're the medical director over a massive organization. So you're hiring, I'm sure, a ton of staff all the time, and I'm sure you're losing a ton of staff all the time. What does the picture look like today as far as bringing people in and keeping them on and keeping them sane and happy?
well, COVID's really thrown a wrench in that. I'll tell you, the best way to keep doctors happy is to let them do doctoring, right? Um, so that means having fully staffed nurses, fully staffed techs, sitters. When someone's suicidal or homicidal, you have to put a sitter on them, someone to watch them, and you can't find a sitter. And so keeping the doctors happy is difficult because we don't have the nursing staff, to really do all of the things that a doctor wants done. And so I think we are seeing more burnout and more turnover.
Yeah. Are you able to do remote sitting in that scenario or no?
It's hard. I mean, you can do remote sitting for patients for safety. Like if you need a sitter to get someone to not fall out of bed,
Right.
right, you can do that.
Right.
But remote sitters for suicidal patients is somewhat controversial. There are hospitals that do it. We're not one of them.
Okay. What do you think? What is the downside to it?
Well, I'm not sure there's a downside to it. It's a little bit of a regulatory nightmare to maintain, um, and uh,
I mean,
hospital.
it makes sense that it's a lot more sensitive than a patient that you're trying to get them to fall out of bed, because if they're trying to get out of bed, they usually just need something and you can help them out. Versus, if a patient is God forbid suicidal or has serious, behavioral or emotional challenges, then that's obviously a totally different
Yeah, that
scenario.
remote sitter needs to have some way of reaching someone
Right.
immediately
Right.
every time.
Right.
And in a busy ED, for example, that's
Right.
not always
You
possible.
go to the
So
bathroom, something. It's done.
yeah, without those safeguards, it's hard to implement.
Yeah. Yeah. So, okay. So let's. When did you? What's the gap between where we left off last? You're working at the small little remote hospital, and now you're medical director at a very large organization. So what transpired in between that?
Well, again, I think just progressive responsibility. So I started with managing one ER.
Okay.
I did a fairly good job, turned it around from a very low performing ED to a higher performing ED, and then got asked to run multiple EDs
Okay.
for the University of Maryland.
What did you implement that turned those around?
Yeah, so I was actually the most interesting thing I did was a high utilizer management plan. So what happens was the small hospital that I was running called Bon Secours had at the time about 30,000 visits per year, and we ran a report that showed that 1,000. I'll remember the number forever because it's such a random number. It was 1,001 patients out of those 30,000 visits were responsible for like I forget now. I don't remember the exact number, but were responsible. Those 1,001 patients were responsible for like half the visits. Okay,
Wow.
they were people who came in all the time. That they had more than six. The requirement to be on the report was to have more than 6 visits in the past 6 months. And the top user had 500 visits in the past 6 months. That means he was coming in multiple times per day.
That's crazy.
I remember the guy. I remember his name. I remember when he died.
Wow.
So uh, so anyway, we created these management plans. Some places call them care plans, where whenever one of these patients would pop into the ER, a plan for taking care of them would come up. Sometimes it was a generic plan, such as, hey, this patient has COPD, and they every time they leave the hospital, they come back very quickly because they don't feel their meds. So just give them all the meds here, um, which is not something we could afford to do for every patient, but for a patient who's going to come back, we knew was going to come back at least 2 more times the next week. It was better just to give them the meds here to go. So that's like one example. And then we also had individualized plans where a committee would come together and say, what are we going to do for this particular patient? And a lot of times it was giving them sort of VIP access to the primary care clinic. So someone would come in with their usual complaint that they come in every week for, and instead of we'd see them, make sure there wasn't anything emergent, and then walk them over to the primary care clinic. So that kind of thing was common.
So then that did not technically become an ER visit.
No, it's an ER visit. It's still an ER visit. But over time, they learned that they could just walk into the primary care clinic. We'd tell them, hey, you don't have to come here. You can just walk into the primary care clinic.
Re-educate a little bit.
Yeah, and that saved an ER visit. And then also, the primary care doctors are much better than the ER doctors at sort of taking care of chronic problems.
Mm-hmm.
And so once they got their chronic problem handled, they started coming in less.
Cool.
And so that was a very successful program that actually now is implemented by the state health information exchange.
Cool.
So I think that was the most innovative thing I did while I was there.
That's awesome. So you start progressing. So now you've got 5 EDs under your leadership. And is that with your current group?
No. So I didn't have 5 at the time. It was a regional ED director. I had the inner city EDs for University of Maryland.
Oh wow. Okay.
And then one of those EDs was the small ED that I started as the chief of, called Bon Secours, and Bon Secours got sold to LifeBridge Health. And because I'd been the chief of the ED, I knew the way that place worked. I'd had some success making it better. LifeBridge asked me to be the chief medical officer of that small hospital.
Okay.
I did that for 6 months. Helped integrate Bon Secours into the LifeBridge system. And then they asked me to be CMO of that hospital plus this larger hospital called Sinai. Wow. So now I'm in charge of Sinai, which is a 500-bed hospital, and we've converted Bon Secours into a new hospital that we call Grace.
Okay.
That now doesn't have any inpatient at all. It only has observation and an ER and a bunch of outpatient clinics, and we're renovating the whole thing.
Wow.
Because it's a community that really needs a presence there, but they don't really need an inpatient presence there.
Right. Now, when you integrate everything, is everything on the same system, same EHRs, same everything?
Yeah, we've been through a bunch of EHR conversions on
sure.
at that hospital. I took it from T-sheets, which were paper charts, to Epic.
Okay.
And then when LifeBridge bought it, we had to convert it from Epic to Cerner, which was a interesting change.
Okay. Yeah, and the fact that I hope people appreciate the fact that you've done that and that you did that in 6 months initially. I mean, I've got clients that they're not changing leadership and they're not changing ownership. They're just changing EHRs. It is a huge deal. It's a big deal.
It's a big deal. I've been through 4 paper to Epic conversions. It's not fun.
Sounds like a lot of scanning or data input.
Yeah, I didn't have to do that, fortunately.
No.
But coming up with I've seen it done different ways. The times I've been in charge of it, I've actually tried to limit choice. Like most EMRs have multiple different ways that you can put something into the system.
Mm-hmm.
And the couple times I've done it where I was in charge of it, I tried to limit that so that there was really only one way to do everything. That way, everyone's doing it the same way,
Uniform.
and that way, when you make changes, it just everyone gets the change kind of pushed to them.
That makes a
When
lot of
people
sense.
do things different ways, and you're trying to make changes, you have to make multiple different changes to get everyone. And so I think those have been successful.
That makes a lot of sense. So, I mean, how many lives does the group have?
Oh, I don't know. Yeah, I mean, the hospital, it's a 500-bed hospital, and we're constantly full.
Yeah,
So,
so probably tens of thousands of lives that are coming through.
well, and LifeBridge Health probably has, many more than that.
Yeah.
But there's a significant outpatient presence,
Right.
run by a different doctor.
Okay.
And
My
so
point is, you're
I
seeing
run
things
inpatient.
from like somewhat of a bird's eye view when it comes, definitely different than a doctor that's running their own practice and seeing 300 patients. So, what do you think are some of? You mentioned a couple things earlier, but in your view, what do you think are some of the challenges that we have as in general in healthcare in the country today, from kind of a high level?
Yeah, so this is a new one that I wouldn't have told you before COVID, but the rising cost of staffing is a problem. Margins in the healthcare industry are low. We're talking 3%, something like that. And when you're spending double on staffing nurses and techs and things like that, it's a problem. And a lot of the reimbursement is fixed, right? It's
Yep.
fixed by insurance companies, it's fixed by the government. So you see rising costs without rising revenues.
Yeah.
Yeah, so it's a problem. And if anything, the government wants to cut revenues.
Yep.
So
Yep. Yeah. They just took down. I mean, CMS in their final ruling, they brought down like their conversion rate. So like a bunch of CPT codes. I mean, nothing major, but every CPT code reimbursement went down by like a tiny percentage. But you lost 75 cents on every procedure. That's a lot.
right, and there were points during the pandemic. It's not the case now, but there were points during the pandemic where the nurses were making $200 an hour.
More
I mean,
what?
the nurses were making $200 an hour.
Wow.
And that's just not sustainable.
Yeah.
Um, and so there's a mix now of staffing that's too expensive to hire and a lack of staffing. We'll have an open position for a care manager, and it's been open for a year. Our care management department staffed at like half its normal staffing.
Sheesh. Do you think that school, like, where do you think the staffing problem starts? Do you think people are not even applying to nursing school anymore, or where do you think the root of the problem is?
Yeah, I think a problem this big probably is multifactorial, right? I think we saw a lot of people kind of call it a day during COVID. I don't need this. We were asking them to do a lot more with a lot less, and
Yep.
so some of it's on us as a system.
Mm-hmm.
Some people individually said, I'm not willing to take this kind of risk. This isn't worth it, and so even though COVID maybe is less risk now, I think people now understand what a pandemic really looks like.
Yeah.
Which we didn't before. When I remember going through the prep for Ebola, right? Where all the nurses and all the docs had to learn how to do the proper gowning and gloving and in the right order so that you didn't get, and it was an exercise. It was interesting. Like it was kind of fun. No one really expected
It's like a
Ebola.
fire drill at school.
Right, it's like a fire drill. But now, people understand that this is real and that, all that stuff is real. And I think, it's a awakening for some people and they've gone and found other careers, which is totally reasonable.
Yeah.
And then that probably decreases the number of applicants into nursing schools and medical schools and whatnot. So.
Right. So if you could, it seems like throughout your career, you've affected change at different levels of the system, and those have all resulted in better outcomes for the patients and the systems. What are maybe some things that either you're working on or you would love to affect at your kind of higher level position now?
Yeah. So right now, I mentioned costs are a problem, right, for us. So we need the staff to provide the care for the patients, right? And if I could just move the patients through the hospital more quickly, I could generate that staff without having to hire more people, right? Because I'd have fewer patients in the hospital. So if our length of stay was some ridiculously short number, say 1 day instead of 6 days, then instead of having 500 people in the hospital, I'd have 200 people in the hospital, and I wouldn't need all this extra staff that I'm paying premium rates for. So reducing the length of stay is something that's on top of mind right now,
Okay.
and it's very difficult because we as a hospital only control a piece of it. For example, when we want to send a patient to a nursing home, okay, prior to COVID, they had double bedded rooms, and now they don't, or they require the patient to be vaccinated and then wait 20 days. In which case, I have to vaccinate them in the hospital, and then they sit here for 20 days while we
Sheesh.
wait or some of them have
Oh,
like a quarantine room that they put every patient in for 14 days prior to bringing them into the facility. But then that means I'm competing with myself and every other hospital in the state to get that 1 or 2 quarantine rooms that they have.
oh my
And then
goodness.
they're also short staffed, right? So getting someone to a nursing home from my hospital, like if we compare two patients who are exactly the same, in every way, except one of them needs to go to a nursing home and one of them's going home. Okay, that patient going home takes about 6 days, and that patient going to a nursing home takes about 14
Oh my.
on
How many?
average. 14,
Oh my gosh.
and so nothing else is different. The only difference is we have to deal with the nursing
You're
home.
just
Oh, and
waiting.
then we have to deal with the insurance companies that provide us authorization to send a patient to the nursing
Right.
home. Right, that takes 3 additional days.
Right.
So the patient's just sitting there, and that's not good for the nurses. That's not good for the hospital system. That's not good for the patient. It's not good for anyone. So if I had anything I could do, it'd be to speed us up a little bit.
That's amazing. Well, Dr. Schabelman, it's fascinating to talk to you. You're one of the people I think we could probably go on for a couple hours, but do want to be respectful of your time. I do hope that we can slowly affect some change in that direction in the country, I guess, from the top. Um, but it sounds like you're doing amazing things, and any patient that goes through your system is lucky. And thank you so much for spending time with us today.
No, thanks, Mendel.